Hi, we're going to talk about the Association of Shelter Veterinarians, Veterinary Task Force to Advance Spay Neuter, and some really important groundbreaking medical guidelines that were published by the task force in 2008. This task force was established in 2006 and originally consisted of 22 veterinary experts in spay neuter practice from all different realms, from academia, from private programs, from stationary clinics, mobile clinics, mash style clinics, feral cat clinics, shelter services, and everything in between. The goal of the task force was to find ways to advance high quality, high volume spay neuter. So here is a list of those 22 veterinarians that first convened, and just a shout out to the ASPCA and PetSmart charities who were both absolutely instrumental in helping to organize and fund this very unique initiative. And here we all are. The initial meeting was actually at Cornell. They put us all in a big room, and we were trying to reach consensus on a number of things. So the moderators got a little wise to us, and they started breaking us into smaller groups because boy, it's difficult to get 22 veterinarians to agree on anything, and even smaller groups. For those of you that know, that's Dr. Phil Bushby. That's me. I love this picture. It's funny. This is, I think, the first time that Dr. Bushby and I met, and we work on many projects together now. But it was really an experience getting together and talking about these things with a diverse group of veterinarians. So we came up first with tasks that we wanted to accomplish. One of those was just to set forth a formal definition that would be published in the veterinary literature for high quality, high volume spay neuter. Also to develop practice guidelines for such, and to consider recruitment and training. How can we bring more veterinarians into this exciting practice area and give them the training and support that they need? And also, wouldn't it be great to be able to point to epidemiologic studies that evaluate the impact and show what amazing progress that we were making helping animals and achieving population control. So those were the tasks that the task force set out to accomplish. We will focus on the definition and then on the practice guidelines that have been, again, published in 2008 by the task force. So here's the definition we came up with. High quality, high volume spay neuter programs are efficient surgical initiatives that meet or exceed veterinary medical standards of care in providing accessible, targeted sterilization of large numbers of cats and dogs in order to reduce their overpopulation. And here's just a picture of our publication, again appearing in JAVMA in 2008. This is a quote from Wikipedia, a definition, if you will, of practice guidelines. And why we believe these guidelines are important is really spelled out nicely in this definition. It says a medical guideline or clinical practice guideline is a document with the aim of guiding decisions and criteria regarding specific areas of health care. Modern medical guidelines are based on the examination of current evidence. They usually include consensus statements on best practices in health care. A healthcare provider is obliged to know the medical guidelines of his or her profession. Modern clinical guidelines identify, summarize, and evaluate the highest quality evidence and most current data about prevention, diagnosis, prognosis, and therapy, including risk, benefit, and cost effectiveness. Additional objectives of clinical guidelines are to raise the quality of care, reduce risk to the patient, and achieve the best balance between cost and medical parameters such as effectiveness. It has been demonstrated repeatedly that the use of guidelines by healthcare providers is an effective way of achieving these objectives. So we set out to develop these practice guidelines for many different types of high volume spay neuter programs. Again, whether it be a stationary clinic, a mobile clinic, in shelter services, in clinics where a private practice actually closes for a day and then runs a high volume clinic within that existing full-service veterinary clinic, programs in veterinary colleges. Innovation really is the limiting factor here, because there's a lot of different programs, diversity, more and more programs all the time. And the idea was to create these practice guidelines to give a level of consistency for them. That being said, we intentionally kept them broad. They are intended as achievable in all these different types of settings, and it's important to recognize that standards may vary depending on local standards and practice acts as well. The goals of the development of these practice guidelines include inaugurating spay-neuter as a practice area, promoting acceptance by the profession and encouraging increased participation, providing guidance for vets, encouraging existing programs to recognize and adhere to the guidelines, promoting confidence in referral by other veterinarians, providing a reference for use by state boards or other governing agencies and professional associations, and also providing a marker for excellence by which donors or funders might evaluate their investment. Of course, one reason this was important, we felt this was important, is because unfortunately, historically, negative perceptions have surrounded high-volume spay-neuter. Sometimes veterinarians working in programs have become concerned about their professional reputations, and many of us have certainly been targeted for complaints, oftentimes unfounded, but nonetheless targeted for complaints. I just wanted to show you, this is the cover of Veterinary Economics. This is right after I graduated from veterinary college, so I think that's why it sticks in my mind, but it says how to keep a humane society hospital out of your community, a highly controversial issue. Here's a quote from the article: "There is no such thing as 50% off safe or 50% off sterile." Indeed, many negative perceptions of high quality or low cost spay-neuter have been repeated by our colleagues over the years. Things like, it's a chop shop, hack and slash with no regard for patient care. This patient has a complication, it must have come from a spay-neuter clinic. If you're making a small incision, you can't possibly be removing the entire reproductive tract. That's very dangerous. Doing high volume surgery cannot possibly be doing a good job. It must certainly be below the standard of care that is acceptable. And these sentiments continue. If you look in Veterinary Economics and other trade magazines and journals, you will see letters to the editor that still circulate on a regular basis right up to the current year, 2013. Here's something from the April 2010 issue, a quote someone wrote in: "I understand why people choose to pay less for services they perceive as identical, but we have to ask, is this the face of veterinary medicine we want to show? The public thinks we all offer the same standards of care. They think that low-cost neutering is the de facto standard of practice. Is our goal low-quality care for every animal? Now, this isn't about competing with low-cost clinics. We can't. They fill a need that most clients see as significant, saving money. But when it comes to these clinics' role in population control, we're kidding ourselves. No studies support these claims. In fact, a recent survey showed that roughly 40% of owned animals are intact. Low-cost neutering and vaccine clinics fill one need, our need to feel good about ourselves." Wow, so you can see that there is still a tremendous amount of conflict and tension among veterinarians who may perceive that this is competition or that services provided are substandard. So again, these are things that the task force wanted to tackle and point out so that we can elevate what is truly an incredibly important aspect of veterinary practice. In order to make services available for all of the animals in need, we need these programs desperately. And I always say, I share a little personal here. It is personal because I too, like many of you that have participated in shelter and spay-neuter practice, have been targeted for complaints. People have said to me, "What are you doing with your credentials?" I can't think of a better thing I could have done with my, quote, credentials, whatever. They've said that, "Why are you working with a spay-neuter program? Is that the only job you can get? Gee, this shelter medicine stuff is a no-brainer." Boy, I find these to be the most challenging things that I've done in my veterinary career. So I'm here to say with absolute certainty that I know that higher volume, or lower cost for that matter, is absolutely not obtained by lowering quality. Support teams, equipment, protocols, everything must be geared towards safety, efficiency, and humane quality care of the large numbers of animals that come to us. And in pursuit of this, the surgeons that are there every day doing these procedures, guess what? You do something all day long, you get really good at it. You become extremely proficient at performing these procedures and develop some very excellent techniques that, yes, may also be time saving, absolutely. But that also makes it a quicker and less invasive surgery for the animal. That is good medicine. So I say it is important work. People are going to fire some shots around you, but that's okay. It just comes with the territory. So the practice guidelines for spay-neuter programs that we developed and published include surgical, anesthetic, and perioperative recommendations. And these are based on accepted principles of research in anesthesia, critical care, micro, surgical asepsis, and technique. We did comprehensive reviews of the scientific literature. We also entertained expert opinions. And again, these are meant as achievable in high volume programs. So we'll start off here with the preoperative guidelines. Goals of the preoperative period, of course, are to address client concerns and expectations, increase patient safety and quality of care, and reduce legal liability. Every time a client comes in, they are asked about patient history, current meds, medical history, allergies. They receive instructions about preoperative fasting, discuss individual patient risk assessment. This can be done very efficiently utilizing forms. And when you have clients that are humane organizations, you can do blanket history on some animals coming in, and also a blanket consent, if you will. So that can be efficient when you have ongoing relationships with some of the people that bring animals into your clinic. So pre-surgical consent forms, they must be reviewed and signed by the client prior to anesthesia and surgery, and of course the specific topic will vary by program, but recommended would be client confirmation of patient's health, acknowledgement of risk of infectious disease, increased risk without current vaccines, anesthetic or surgical risk, including death, authorization for surgery, recommendation for ongoing total health care by a full-service veterinary clinic, and client contact information for emergency purposes. Medical records are required for every patient. Doesn't matter how many we do, we have to have an individual patient record for each, and that should contain the results of physical examination, weight, dosages, routes of all drugs, the surgical procedure, and any abnormalities. These, of course, have to be in accordance with state and local practice laws, and they're guided by state and national veterinary medical associations. You can use standardized operative forms. There's no problem with that, as long as you make exceptions when that needs to be noted that something was different or deviated from the standard report. Vaccination is always recommended prior to surgery, but perioperative vaccination is absolutely acceptable when necessary. We know these animals, even at the time of surgery, will have a robust immune response to a modified live vaccination. Rabies vaccines, of course, are required or administered as mandated by state regulations, and we do recommend that vaccine protocols follow current AAFP and AHA guidelines. Patient fasting for dogs and cats is always ideal. It's not recommended nor necessary to withhold water, and prolonged fasting isn't warranted. 4 to 6 hours is recommended for cats and dogs routinely, and only 2 to 4 hours for pediatric patients. It's very important for pediatric patients not to have a prolonged fasting, as that can contribute substantially to hypoglycemia and complications, including poor recoveries and so forth. In terms of patient selection, it will vary depending on the clinic staffing, your capabilities in terms of anesthesia, and the technical proficiency of the surgeons and the training of the technicians, and possibly economics as well. Physical examination is critically important. Animals should be screened in very thoroughly but yet efficiently by a veterinarian or a vet student under their supervision. And they should this should be done prior to anesthesia with the exception of feral status, aggression, severe anxiety, and then that would be at the vet's discretion that perhaps the animal receive the examination after sedation or induction. So at the veterinarian's discretion then would be the timing of the physical examination, a temperature assessment if that is deemed necessary, and then any pre-anesthetic diagnostic testing. Doesn't necessarily mean that we need to routinely do these things on these young healthy patients, but it is at the vet's discretion to either recommend that or decline the animal because we're uncomfortable with that animal's physical exam findings, and we recommend that they have further workup before they have surgery. Gender and body weight. Gender and reproductive status should be verified prior to anesthesia and surgery. Body weight as close to surgery as possible. It might have to be estimated rather in feral and fractious patients, and of course that's going to be used to guide drug choices, drug dosing, etc. The final decision regarding acceptance of a patient is the vet's discretion based on history, physical, the clinical surgical schedule, and their clinical skills. Minimum and maximum age and weight is at their discretion. It's based on the program expertise. Many veterinarians in high quality, high volume programs use a general rule of thumb of 6 weeks of age and 2 pounds body weight, but that certainly does vary depending on the expertise of the program. Patients with mild infectious or other disease very commonly present to our programs, and we have to weigh the risks and benefits of that. When this is likely to be a one-time opportunity for spay-neuter, the risk-benefit ratio falls in favor of operating on many of these animals. When we select these patients that have mild disease, parasite infection, heartworm disease, etc., we may have to adjust anesthesia and perioperative care accordingly. We also see a number of animals that present to us pregnant with pyometra in heat spays, and these can all be routinely performed in the high volume, high quality setting, provided animals are not otherwise compromised. These are very routinely done. Patient housing. Housing should allow for patient safety and comfort. It should be appropriate for each individual animal. There should be a system in place for ID of animals. There should be adequate temperature and ventilation and stress reduction, proper cleaning and disinfection between patients. Adult tractable animals should generally be housed in individual enclosures with good visibility, adequate turnaround and space that allow for safety at various stages of sedation and anesthesia. Pediatrics, on the other hand, they benefit from being housed together for many reasons, including warmth and the decreasing separation stress that is very important for these young animals. Intractable or feral animals might best be served by being housed in traps or other enclosures that would allow for easy administration of anesthetics without extensive handling, which is going to increase staff safety and decrease animal stress. They should be removed for surgery only after they are fully sedated or induced, and then return to their enclosure as soon as safely possible. Infectious disease control obviously is very important, as is typical for any surgery or clinic. Standard protocols should be in place and should be routinely practiced. All equipment that has direct patient contact, such as ET tubes, should be thoroughly cleaned and disinfected between patients. Breathing circuits should be cleaned, disinfected, and dried 1 to 2 times per week at minimum with daily use. Dome and one-way valves and absorbent canisters should be disassembled and cleaned weekly. Staff, of course, should wash their hands between patients and litters, and surgery of infected animals should follow healthy animals within the day's schedule. Pre-op equipment check. An equipment safety checklist is one of the best things that we can do to improve safety in the OR. It should be performed prior to anesthesia on a regularly scheduled basis. Things like general machine inspection, confirmation of oxygen supply, breathing circuit check, ventilator safety and function check, all crucially important. The scavenge system should be in use. Active and passive systems are acceptable. Charcoal canisters are acceptable, but only for short-term use, usually less than 8 hours, or is determined by the weight of the canister. So those were just a few of the preoperative guidelines that are defined in our publication. We're going to talk now about anesthesia guidelines. At the top of the list is preparation for emergencies. Emergency readiness is absolutely essential. Crash kit needs to be fully stocked. We should have emergency drug charts on hand, and staff should have regular training and rounds so that they know what to do should there be an emergency. It will make all the difference. In terms of anesthesia protocol, selection will depend on many different facets of the program: the daily schedule, the skill and efficiency of the technical staff and surgeons, and also financial considerations. Regardless, the protocol needs to provide long-term analgesia to include the post-op period, stress reduction, muscle relaxation, and of course safe control, reversible loss of consciousness. It's recommended that programs develop general use protocols, and if they are going to occasionally have a higher risk patient that they accept for surgery, there should be a high risk protocol in place as well. That's perhaps includes oxygenation and would be less cardiodepressive. This is just an example of some things that we might do for the high-risk patient. They may also be given fluids, and certainly additional monitoring may be necessary as well. Accurate drug calculation and administration is always essential. There can be no estimation on a routine basis of just guessing weights when these animals come in. The dose needs to be based on weight. If it's a situation where we cannot weigh the animal, then selecting an anesthetic cocktail with a wider safety margin and giving a dosage range based on the size of the animal, as we often do for feral cats, would be very, very important. In general, though, we avoid one-size-fits-all dosing. We recognize the success of anesthesia is going to depend on the care of animals perioperatively, thermoregulation being so important, appropriate fasting, etc. The flow of cases, always keeping an eye on stress reduction, making modifications to fit individual patient needs as we go, and vigilant hands-on monitoring from induction to recovery. There's no substitute for that vigilant hands-on monitoring. We must have that for every patient in a high-volume setting. Thermoregulation is super important. Think ahead from the time of pre-med onward. Reduce cold contacts with cold environments. Provide some sort of bedding. Many different things can be used to help warm animals, from circulating warm water blankets to rice mamas and rice bottles, etc., as long as they're used safely to prevent thermal burns. Avoid wide surgical clips, moistening of the hair coat, cold sub-Q fluids, aggressive scrubbing, alcohol, things that are going to hasten loss of body temperature. So many different ways for us to work to prevent hypothermia. This is probably the single most important thing that you can do, and really it should begin in the preoperative period, keeping those patients warm from the time that they enter the clinic until they are fully recovered. So again, a few other things: the rice mamas, which is just rice in a sock, and then you warm that in the microwave, or you can use just a cold pack and warm that in the microwave. Be sure to use standoff contact so that we prevent thermal burns. Hypothermia is a very bad thing. It delays recovery. It can increase pain and bleeding. It can lead to wound infections, and it can certainly lead to cardiac compromise, bradycardia, arrhythmias, and start a really negative spiral. So it's, again, the single most important thing we can do for these patients is to keep them warm. What about fluid therapy and oxygenation? Well, these should be possibilities. They should be available for all patients. It doesn't necessarily mean that we need to give them to all patients. They are especially helpful when a patient is debilitated, compromised, or at high risk for some reason. They may be particularly indicated. Fluid therapy, of course, is going to improve hydration as well as perfusion and organ function, drug performance, and can smooth out recovery. We need to avoid giving very cold fluids. if we're going to give subcutaneous fluids, it can predispose patients to hypothermia if they're given in the pre-op time, so we generally recommend doing that as the patient is waking up and getting warm, and always warming those. If we need to directly improve volume, then intravenous fluids would be the way to go. So anesthetic monitoring, monitor many variables versus one. Always focus on trends instead of looking at a value one time. No monitor will replace a well-trained individual. So hands-on monitoring for pulse quality, rate and rhythm, respiratory rate and pattern, temperature, jaw tone, eye position, all of those things. Beware of looking only at mucous membrane color. Animals can remain pink even after cardiac standstill and for some time in some cases. Also be aware that we can see problems with the different monitors, and just watching the bag for movement can be misleading as well because of abdominal movements that the surgeon may make can make you mistake actual respirations. So we do recommend in general that pulse oximetry is a nice way to monitor, and lack of any objective means or a single means, we should be on the lookout for that. In terms of anesthesia protocol, again, the selection will depend on the daily schedule, the skill and efficiency of technical staff, and financial considerations, but we want to be sure that we have provided for a balance regardless of the protocol that we use. So that just warrants repeating because it is such an important point. Building on that, we need to really think in particular about analgesia. This is absolutely required for all patients. Those anesthetic protocols should have them built in preemptively. Multimodal analgesia is the way to go, utilizing different types of drugs from opioids to alpha-2s to NSAIDs in some cases. Again, numerous protocols exist combining different drugs, anxiolytics, analgesics, and induction agents into a single injection can be very efficient and also reduce patient stress, and can be a very effective way of delivering an anesthesia agent to these animals. Pain medication should always be included in the plan within the protocol itself, and in some cases to go home, that may mean that we are giving a dose of medication in the clinic in the postoperative period that will last as the animal goes home, and in a few cases we may also be sending medications home with these animals when necessary for ongoing pain control at home. Anticholinergics are not routinely recommended, probably because we have an improved understanding now of the possible mal effects of these, and so many protocols do not include these because tachycardias simply aren't as healthy as we once thought that they were. What about intubation? This is always a question that we face a lot, and what do the guidelines say about intubation? The guidelines do discuss the pros and cons of it. Obviously, intubation assures a patent protected airway. The cons are is that it requires experience, a heavy depth of anesthesia. It takes time and can create problems if not done with skill, tracheal tears, laryngeal inflammation, and also we worry about the infection potential because these all have the possibility of being fomites, especially in this high volume setting where we may be seeing a lot of shelter animals as well, so we worry about that. So making that decision to intubate or not, you have to weigh those pros and cons. Certainly not every patient must be intubated, but it should be a possibility in case of emergency. Those that probably should be routinely intubated are brachycephalic animals, those with upper respiratory disease, and those that are overweight. Mask and chamber induction, generally not recommended because of the poorly controlled loss of consciousness that comes with these methods. Very, very stressful. We see sympathomimetic effects, bronchoirritation, waste gas contamination. This is a problem for staff, an increased risk of aspiration, and it's also expensive. Sometimes mask maintenance might be indicated. Realistically, it's going to be required for some patients, or we may have animals on mask maintenance at a very, very, very low flow rate where we don't have significant waste gas issues for our staff, and we can provide a source of oxygenation. If it has to be used frequently to keep animals down during surgery, then we need to take a look at our anesthetic protocol and think about intubation or employing better analgesics and sedatives to provide a more complete and balanced anesthesia. I do want to mention the broad belt CEPSAF studies. CEPSAF stands for Confidential Inquiry into Perioperative Small Animal Fatalities. And these studies are going to be discussed a bit more in the community cat management course, but these studies came after we published these spay-neuter guidelines. And I should tell you, we're in the very, very early stages of a second edition, if you will, of the guidelines, and so you are going to see some changes. There probably will be some changes that are made to recommendations based on this new information. But this study looked at the risk of anesthesia in dogs and cats today. They collected data from vet practices and recorded patient outcome after pre-med and within 48 hours of the end of the procedure, and looked at species-specific risks and anesthetic-related death. They did cats, dogs, rabbits, and others, again generating mortality rates and risk factors for each. The CEPSAF study included almost 100,000 dogs and almost 80,000 cats, and the numbers were just amazing in those. And here you see the mortality rates: 0.05 for dogs, higher risk for cats at 0.11. And even though those are low, we can do better, and we should definitely strive to do better, because when that's your patient, your animal, that's 100% for you. So the results of the study, again, looked at dogs and cats. In dogs that were small, less than 5 kilograms, it did show they have a higher risk of mortality. This may be due to hypothermia that we've already talked about, or inaccurate dosing. So very, very important for these small animals. Sometimes we need to dilute our stock solutions to be sure we're getting very accurate dosing and be sure that we're weighing these animals. Sometimes with these small animals, veterinarians may have a tendency to mask them down because they can't get IV access or adequately restrain them. We know from this study that that is very dangerous and increases the risk of mortality very significantly. You can see that the time of death often is in the immediate post-op period, the first 3 hours after surgery. So very crucial to have monitoring, and again to be very cognizant of body temperature and prevention of hypothermia. Other risk factors were geriatric dogs were at higher risk of mortality, and those animals that underwent a lengthy procedure, in other words, greater than 30 minutes. So some very important information gleaned from this study. Similarly, they also looked at cats. Small size was also a risk factor in cats, and respiratory obstruction was very common in cats, especially in the post-op period. Look at how many kitties were lost in the post-op period. So very, very important for cats. The post-op obstruction, respiratory obstruction, may well be related to intubation resulting in airway trauma, edema, increased risk for laryngospasm. After all, they are cats. So very, very important to weigh the pros and cons of intubation. We know that more than ever now after this study. IV fluids were also noted to be a risk factor for increasing the risk of mortality, possibly because cats can be so easily overloaded, or they may have occult cardiomyopathy. So very important things to think about. Intubation, in fact, in the study increased the odds 3 times for serious complications or mortality for short procedures. Short procedure defined as less than 30 minutes. So we need to have intubation supplies ready We could give oxygen more safely by a mask, but perhaps we should not be routinely intubating cats, and many people have changed their protocols now away from intubation of cats based on the results of this study, probably with some exceptions like these guys, or cats that are otherwise have some sort of upper airway compromise. But in general, we say probably would not intubate a cat if the procedure is less than 30 minutes and it's a healthy cat. Yes, if it's a long procedure, a sick cat, an overweight cat. So that is just a glimpse at the anesthesia standards and how they may evolve now that we have more information about anesthesia safety based on those SEPSAF studies. We may see other changes and tweaks as our clinical experience and results of research such as that have been gleaned. We'll talk now briefly about surgical standards of care. The OR environment, this is a broad definition of OR because it may be a MASH style program, in other words, a program that goes out remotely and sets up somewhere, or a mobile operation that's contained on a mobile unit. Regardless, it's a dedicated surgical area with proper equipment. It's very important, that being said, it's very important to recognize that the OR environment must meet state board regulations. Traffic should be limited to essential surgical personnel. In terms of surgical pack preparation, we need true sterile instrumentation. No cold sterile, we need to be using steam, ET oxide, plasma, all of those would be fine, and we need separate sterile instruments for each patient. Now, even though we need separate sterile instruments for each patient, there are ways to be very efficient. Let's say you're going to neuter a whole bunch of tomcats and you only need a hemostat to do that. You could have a very large pack of hemostats, and using sterile technique, remove one instrument for each new cat that you get. So you're still accomplishing using separate sterile instruments for each cat, but in a more efficient way perhaps than wrapping them all individually. So just a few words about surgical pack preparation. In terms of patient prep, removing the hair, being sure that we have a good surgical scrub in accordance with accepted guidelines for patient prep. Draping should absolutely be done for all abdominal procedures, as well as for canine castration, with the exception of pediatrics, and then draping is optional at the surgeon's discretion for feline and pediatric canine castration if we can maintain good aseptic technique without it. But certainly nothing wrong with draping all of these guys. In terms of surgeon preparation, attire, appropriate surgical attire, gown is preferred, but its use is at the surgeon's discretion. Caps, masks are required except for cat and puppy neuters. Surgeon hand and arm scrub, appropriate scrub with approved product. Sterile single-use surgical gloves with the exception of feline castration when we could use a regular exam gloves. But again, they need to be single-use, but they don't necessarily have to be sterile surgical gloves. They could be exam gloves. The surgical procedures obviously must be performed by veterinarians or veterinary students under their direct supervision. We always have to adhere to the golden surgical principles: gentle tissue handling, meticulous hemostasis, and outstanding aseptic technique. Always ensure and verify hemostasis. Using interrupted or continuous suture patterns are acceptable. For females, ventral midline, flank, or laparoscopic approaches at the surgeon's discretion. Removal of the ovaries and uterus, or just ovariectomy at the surgeon's discretion. We draw the line and say we must remove both ovaries, so always have to get both ovaries. So the exact procedure, the length and location of the incision is always the surgeon's preference. Closure, if there was a ventral midline incision, must include the rectus sheath, and if it was a flank incision, closure of the transversus abdominis and internal and external abdominal obliques is required. For males, castration, prescrotal and scrotal approaches are absolutely acceptable. It doesn't matter whether it's a dog or a cat, a puppy, a kitten, an adult animal, scrotal or prescrotal approaches are acceptable. These techniques have been described in surgery textbooks and are absolutely appropriate if the surgeon is most comfortable with that, if that is their preference. Again, we draw the line at saying we've got to remove both testicles. And don't just remove one in a cryptorchid animal. We must remove both testicles. What about pediatric surgeries? What do the guidelines say about pediatrics? Well, we say these techniques have been well described, and they can absolutely be safely, routinely done, with the specifics of those techniques left to the surgeon's preference. Surgical materials, always biomedical grade. No cable ties, no sewing thread, no baling twine. It is acceptable to use inert, non-absorbable suture materials such as stainless steel or nylon. That's absolutely fine, or you can use an absorbable as long as it's a biomedical grade. Again, continuous or interrupted patterns are fine. In terms of identification of spayed and neutered animals, the guidelines call for an identifying mark. We use ear tipping for feral or community cats. Tattooing is recommended for all others along the ventral abdominal location using sterile instrumentation with the method left to the surgeon, but this can greatly aid in identification of a neutered animal. In general, routine use of antibiotics is not recommended unless there is specific indications such as pyometra or break-in surgical asepsis. There is some new information that has been published since we wrote these guidelines, so I think this statement will be under review in the next edition. I don't know if it will change or not, but it's something to think about for the future. And that's where we'll end the surgical guidelines. We'll talk for a few minutes about the post-op guidelines now. These are some very committed cat caregivers here helping to recover some kitties. Again, that vigilant, direct observation that's so important to a positive outcome during the post-operative period. So patient recovery, careful transport, safe delivery to the recovery area, continuous direct observation in a clean, dry, warm environment. For our pediatrics, we've got to prevent hypoglycemia and hypothermia. We've got to ensure that those pediatric patients eat very soon after surgery. We allow them to recover together once they have their righting reflexes, and it's safe to do so to reduce, again, separation stress and to help promote normothermia. So again, continuous direct observation of patients. Cannot spell that out enough. It's such an essential component of that standard of care in these high volume settings. We're going to be looking at heart rate and pulse quality. Except in feral animals, after the first signs of recovery, they may have to be back in their traps where it's safe, but we're still doing hands-on visual monitoring. Assessing for airway patency, keeping the head and neck extended. Very important when you put the feral cats back in the traps that they're in there straight, that their head and neck is fully extended to help keep that airway patent. Looking at respiratory rate and character, pain, anxiety, degree of arousal or sedation, movement, all of those things. Thermoregulation, I think we have really emphasized how important that is, monitoring body temperature as needed. When an animal is a little bit slow to recover, it's one of the first things that you want to assess is what is that animal's body temperature. Staying on top of your pain control, giving additional analgesics as needed in the postoperative period. The question about anesthetic reversal in the postoperative period often comes up. Programs want to get these animals up so they can get them out. We always want to bear in mind that when we reverse an anesthetic agent, it also reverses their analgesic properties, and so that can result in pain and anxiety. We do need to balance this, though, with the need to promptly return an animal to their environment, and certainly in an emergency case, reversal is going to be indicated. Postoperative housing and care, verifying ID prior to return to housing, continuing to evaluate, keeping them clean and dry if they are held overnight, providing food and water, and access to area for urination, defecation. Dogs may need to be walked, especially, again, if they're housed over 12 hours. Providing food for the pediatrics. Very hungry. They need to eat very soon after surgery. As soon as they are able to stand up, they need to be fed. Patient transport. Some programs routinely transport in large numbers of animals for surgery. So obviously we want to have safe and comfortable temperatures in the vehicles with proper confinement and securing of the enclosures, as well as monitoring of the animals during transport to be sure everyone's okay. And release, evaluating patients prior to release, being sure they're alert, they're able to stand or walk, they're not experiencing pain, that they have normal respiratory rate and character, and checking the incision whenever possible to be sure that it's clean, dry, and intact. Owner guardian instructions should be given both in a written form and also verbally to make sure that there are very good instructions relayed for post-operative care, including resources and contacts for questions, concerns, and emergencies. Again, for organizations that you work with on a regular basis, this may be done in a blanket standing way, but for all others, that individual instruction is very important. It can be done in a group setting, like at a mass discharging of many clients. We can go over these instructions with a large group to make us more efficient. So, an example of written instructions, and always giving them verbal instructions again as well. Finally, emergencies and complications. We must have a plan to deal with these. When possible, a clinic should perform its own rechecks. It doesn't mean that you have to be open 24/7. Emergencies may be referred, but a clear plan needs to be in place. In the event of a death, a necropsy should be performed. If possible, at a diagnostic lab that would be a neutral source within the clinic with appropriate documentation is also acceptable. In conclusion, just want to say again, emphasize what an incredibly important practice area spay-neuter is. High volume and high quality can absolutely be achieved. These programs are unbelievably important. They do increase the number of cats and dogs that are sterilized in communities, with the goal of ultimately decreasing euthanasia of cats and dogs. Again, a shout out of thanks to PetSmart Charities and the ASPCA, who have given so much support to the ASV Task Force to help us with these guidelines and other projects designed to advance high quality, high volume spay-neuter.